Welcome to episode 255 of Real Health Radio. You can find the show notes and the links talked about as part of this episode at 7, so the word all spelled out, SEVEN health.com/255. Before we get started, I just want to mention that I'm taking on new clients. I specialize in helping clients overcome eating disorders and disordered eating, chronic dieting, body dissatisfaction and poor body image, exercise compulsion and over-exercising, and also helping clients to regain their periods. If you want help in any of these areas, or you simply want support to improve your relationship with food and body and exercise, then please get in contact. You can head over to 7-health.com/help, and there you can read about how I work with clients and apply for a free initial chat. So the address again is 7-health.com/help, and I'll also include that in the show notes. Hey everyone, welcome back to another episode of Real Health Radio. I'm your host, Chris Sandel. I'm a nutritionist that specializes in recovery from disordered eating and eating disorders, or really just helping anyone who has a messy relationship with food and body and exercise. And today on the show, it's a solo episode. And I really enjoy doing the recent solo episodes with episode 249 on how to heal from trauma, and then the AMA episode for the 250th show. And today's episode is all about eating disorder recovery. And this is something I have written about before. I've done specific articles on anorexia recovery and binge eating disorder recovery. And I plan to do articles on bulimia and orthorexia at some point this year, and then articles on other eating disorders after that. But what I want to do today is look at eating disorder recovery as a whole. What does the process entail? And with all eating disorders, there are differences and things that make them unique, which I'll speak to and cover as part of this episode. But actually, what I've found from doing this work for such a long time now, and through working with many different types of eating disorders, is that there is a lot of overlap. That while, say, binge eating disorder and anorexia may appear different on the surface, they actually have a lot more in common than they have differences. And if you listen to my conversation with Sasha Gorel, which was episode 246 of the podcast, this was actually something that we chatted about, where with all eating disorders, there are similarities. And the similarities that she pointed out are, 1, there is a fear of the consequences of eating. 2, there is weight suppression. And this is a weight that is lower than this person was historically at. And 3, there are then behaviors that maintain the eating disorder. And with the clients I work with, especially for clients with long-standing eating disorders, it's often that they present differently over time. And so at one point, they would have received a diagnosis for binge eating disorder, and then there was a period where bulimia was occurring, and then later on it was anorexia, and then they go into a phase of more quasi-recovery that would be more likely diagnosed as orthorexia. And this obviously isn't the case with everyone, but it does happen more frequently than you'd probably imagine. But in terms of the similarities that I talked about before, with the fear of consequences of eating, with the weight suppression, with the behaviors that maintain the eating disorder, these have stayed throughout all of those different changes. So as a starting point, I think it would be useful to go through each of the eating disorders and look at the diagnostic criteria. And a diagnosis is made using the criteria in the DSM-5, which is the 5th edition of the Diagnostic and Statistic Manual of Mental Disorders. I am not a psychiatrist, and it's never my job to diagnose an eating disorder, but I can at least look at the criteria with a client to see if this describes their experience in any way. I should add that I think there are huge limitations with the diagnostic criteria, and it can be very black and white, but we can talk about this more broadly. I then want to go through a list of symptoms that often occur because of an eating disorder. And some of these will be more common in one disorder over another, but it can be a good way of noticing if you are experiencing a couple of them, if you're experiencing many of them. And then we can look at the various aspects of recovery. So if you're doing recovery on your own, how you can assess how well you're doing, or how often you're doing these certain things, or are you actually focusing on these certain areas? Or if you're working with a provider or thinking of working with a provider, you can assess how much of these are part of the recovery process on offer. And the show notes for this episode are going to be filled with lots of resources that I mentioned throughout the show. And some of those will be articles, some of them will be other podcasts, but I highly recommend checking out that page because there's going to be a lot of information there. And it's at 7-health.com/255. So let's start with looking at the different types of eating disorders, and first starting with anorexia. So anorexia nervosa, often just shortened to anorexia, is a mental illness that is characterized by a preoccupation with restricting food and fear connected to weight. To receive a diagnosis of anorexia, you need to meet the following criteria. So one is restriction of energy intake relative to requirements leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. 2, intense fear of gaining weight or becoming fat, even though underweight. And then 3, disturbances in the way in which one's body or shape is experienced, undue influence of body weight or shape on evaluation, or denial of the seriousness of the current low body weight. Now, there are different subtypes of anorexia, and I think it's important to mention this because while we have a stereotypical view of what anorexia looks like or what someone's eating behaviors will be, it can be different to these narrow ideas. So the first subtype is the restricting type, and this is the subtype that is the most stereotypical of anorexia, where someone consistently restricts without engaging in binge eating. The next subtype is the binge purge type, and this subtype is where someone has regular instances of binging and or purging, and purging can include vomiting, laxatives, diuretics, enemas, or more commonly compensatory exercise and fasting. And these behaviors are used to deal with the supposed extra calories. And then the third one is atypical anorexia. And this is where someone meets the criteria for anorexia, except they aren't living in what is considered a low body weight. And I want to linger on this final subtype, the atypical type, because it really points towards a bigger problem we have both in society at large, but also within the medical profession when we think about anorexia. Because while we have a bias of what anorexia or malnutrition looks like, the vast majority of people don't match up to this stereotype in how they look. Because while I said there are 3 categories or subtypes of anorexia, there's only officially 2 of them. So there's the restricting subtype and then the binge purge subtype. The atypical subtype falls under the category of other specified feeding or eating disorder, which is shortened to OSFED, which was previously known as eating disorder not otherwise specified. And OSFED is the catch-all for those that meet up with some criteria for diagnosis, but not all of them. So in the case of anorexia, it's they meet the criteria except their weight isn't low, or in the case of binge eating disorder or bulimia, the binge episodes or the binge purge episodes are happening, but they're not happening frequently enough. And let me just add some statistics to this to get a sense of why this is a problem. So for example, there is a paper that I'll link to in the show notes that's called Prevalence, Incidence, Impairment and Course of the Proposed DSM-5 Eating Disorder Diagnosis in an 8-year prospective community study of young women. Very catchy title. And they looked at the lifetime prevalence of an eating disorder by age 20. And the prevalence of low-weight anorexia was 0.0% of the population they studied, and the prevalence for atypical anorexia was 2.8% of the population. So atypical in this sample size is occurring more than 3 times the amount that the low-weight anorexia is occurring. So really, if anything should be called atypical, it should be the low-weight anorexia because it's happening much less frequently. There is another paper that I'll link to that is called Prevalence of Eating Disorders over the 2000 to 2018 period, a systematic literature review. And it shows that the eating disorder category with the highest prevalence is the EDNOS. And they found that the weighted mean prevalence of this was 10% or 10.1% for females and 0.9% for males. And by point of comparison, it put the prevalence of bulimia at 1.5% for females and 0.1% for males. For binge eating disorder, it was 2.3% for females and 0.3% for males, and anorexia at 1.4% for females and 0.2% for males. meaning that the vast majority of people diagnosed with an eating disorder don't match up to the criteria for a specific diagnosis and fall into this extra category. And as an aside, I would add that the figures for males with eating disorders that I just quoted, I think are grossly underreporting what is really going on. Like, men are affected much more frequently than those statistics would make out, which is a topic for a whole other episode, but I felt that I needed to comment it on. But really, the overarching message here is it's important to realize that just because someone isn't in a small or emaciated body doesn't mean that they aren't suffering. And anorexia and eating disorders more generally affect people of all shapes and sizes, and someone shouldn't have to reach some specific size or frequency of behavior before we deem them as worthy of needing treatment. And it really is abhorrent that the thoughts and behaviors considered a disease in one person in one body size are considered a great plan or a solution for someone in a different body size. It's also important to note that even if you don't meet the official diagnosis, you can still be struggling. And as I'm demonstrating, rather than eating disorders being a binary issue where you either have one or you don't, it's more like a continuum. And there will be many people who don't meet the criteria for a diagnosable eating disorder and aren't even assessed to meet the criteria for OSFED. But this doesn't mean that they are in the clear. And disordered eating is then the term that is used as a catch-all to describe the issues with food outside of an official diagnosis. And this is something I want you to keep in mind when I go through each of these eating disorders, that just because you may not match up to the official criteria doesn't mean that everything is fine. And this is why looking at symptoms can be so useful and is what I'll do after I go through the criteria. So a couple of things I want to mention, and this connects to the binge purge form of anorexia. One is that I really think it's important that we know that this is a category, because so often clients will think that they can't possibly have anorexia because they have episodes of binging. Well, just because there are episodes of binging doesn't rule out anorexia. And the same thoughts can occur for those who meet the criteria for the restricting subtype. They can think that they are eating food. It's not that they don't eat any food. And to them, it feels like they eat a lot of food. And so, again, they rationalize, I can't possibly have anorexia because I don't match up to what I think is the stereotypical view of anorexia. The other thing I would add is that often people start out at the restrictive subtype, but with time it becomes the binge purge subtype, where they can't restrict in the way that they could before. For example, this is when exercise then starts to increase, often drastically so, to try and compensate. And this can often be the point when someone seeks treatment, because now binge is occurring, it's finally seen as a problem. Or even if treatment isn't sought, at this point, it's still thought of as a defining or a watershed moment. Like, this is when they started seeing it as a problem. Or this is the point that for them proves that they don't have anorexia because they are really a binge eater and that the binge eating is the problem. But again, it's worth knowing that just because binges occur doesn't mean that you no longer have anorexia. So the next eating disorder I want to look at is binge eating disorder, often shortened to BED. And to receive a diagnosis, you need to meet the following criteria. So 1, recurrent episodes of binge eating. An episode of binge eating is characterized by both of the following. So 1, eating in a discrete period of time, for example, within any 2-hour period, an amount of food that is definitely larger than most people would eat in a similar period of time under similar circumstances. And 2, a sense of lack of control over eating during the episode. For example, a feeling that one cannot stop eating or control what or how one is eating. The next is the binge eating episodes are associated with 3 or more of the following: eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not physically hungry, eating alone because of feeling embarrassed by how much one is eating, feeling disgusted by oneself, depressed, or very guilty afterwards. The next category is 3, or next criteria is 3, marked distress regarding that binge eating is present. 4, the binge eating occurs on average at least once a week for 3 months. And 5, the binge eating is not associated with the recurrent use of inappropriate compensatory behaviors, for example, purging, and does not occur exclusively during the course of anorexia nervosa, bulimia nervosa, or avoidant restrictive food intake disorder. So I need to add some more color and explanation to the above. As a society, we use the word binge in connection to a wide variety of experiences with food, and it's often used quite flippantly when describing eating a chocolate bar or a piece of cake. But in the case of binge eating disorder, the word has a very different meaning and is part of a very different experience. And it's not simply a case of having an occasional time of eating past the point of fullness. It is the experience of losing control when eating and having your relationship with food completely changed over time because of this. And food can become adversarial, where you try your best to avoid it, but it also can be the thing that is turned to, often unintentionally, as a way to deal with difficult feelings or difficult situations. And it can be very upsetting and maddening in terms of the powerlessness that one can begin to feel around food. And no matter how much willpower one applies or how many times you tell yourself like never again, it reoccurs. And even with all the shame or the guilt or the disgust or the physical discomfort from the experience and the aftermath of that binge, it still isn't enough to prevent it from happening again. And a big reason that I see this is happening is because I feel there is a mix-up between what is the driver and what is the symptom, or mistaking the symptom for where the problem really lies. So, for example, everyone believes that the binges are the problem, that if I can simply stop the binges by learning how to control myself, then the problem will fix. But the binge is actually the symptom. Like the real driver is restriction, dieting or dieting mentality, and eating large amounts of food is the body's response to this restriction. And this is known as the diet binge cycle, where you restrict or diet, it then becomes too much and you have a binge, you feel terrible and decide you need to restrict and diet again, and the cycle continues. And a common response to this information when I mention this to clients is like, but I'm not restricting. And I would say, given the world that we live in, this makes sense because restriction has become so encouraged and normalized that we've stopped even thinking of it as restriction. And restrictive practices are rebranded as health promoting and biohacking. And we can add a moralistic tone to them where you're a good or a virtuous person for pursuing them. And diet culture is so ubiquitous that we just don't see it. And with every client that I work with binge eating disorder, restriction is a central part of the problem, even if in the beginning the client is unable to see that this is true. And this isn't to say that it is only about restriction. There can be many other components connected to this, and most often there are, and these are all need to be worked on, and these are things that I'm going to go through when we get to all the things that are part of the recovery process. But I am yet to see a case of binge eating disorder where restriction wasn't present and where it wasn't having a primary role in driving it. And I've actually done a whole podcast on restriction, which if you haven't listened to, I'd highly suggest checking out because it goes way beyond what most people think of as restriction and can be rather enlightening. So it's episode 214 of the show, and I'll add it to the show notes. Now, back to the criteria for binge eating disorder. So criteria 4 states that the binge eating occurs on average at least once a week for 3 months. I wouldn't get too hung up on this and think that it can be happening less frequently and obviously still be a problem. So even if this would mean that someone falls into the disordered eating category or the offset category instead of getting an official diagnosis of binge eating disorder, this can still be thought about as serious. Criteria 5 states that the binge eating is not associated with the recurrent use of inappropriate compensatory behaviors, for example, purging, and does not occur exclusively during the course of anorexia nervosa, bulimia nervosa, or avoidant restrictive food intake disorder. I talked earlier about atypical anorexia, and I think that many people who are diagnosed with binge eating disorder actually meet the criteria for atypical anorexia binge purge subtype. So like combining those two subtypes together. And the only reason they don't get this diagnosis is because of our weight bias and the fear that we have in society of weight gain. And this then combined with the distress caused by the binges and the focus then being placed on them. And in some ways, it is semantics. Like, if the focus is on recovery, the actual label doesn't matter. But in many ways, it does matter, because often the way that treatment is structured for binge eating disorder is different than it is for anorexia recovery. And with binge eating disorder treatment, the binges are then seen as the problem rather than the symptom. I would also say that for the individual, they would think differently about the issue if there was a diagnosis of anorexia rather than binge eating disorder. And largely because of the stereotype connected with binge eating disorder versus with anorexia. So whenever I look at the statistics around eating disorders and see that binge eating disorder outside of offset is the one diagnosed most often, I'm always aware of the biases that are playing into this. The final thing I want to mention is that binges can be both intentional and unintentional. So where someone plans to have a binge and goes and buys food in preparation for this, or where someone starts eating and then it turns into a binge. And interestingly, in this second category with the unintentional binge, there's often some imagined line that has been crossed that then leads to the binge. So a meal has been eaten or is being eaten, and then there's the realization that they have eaten a certain amount of food and yet are still hungry or are still craving more or are craving something different. And it can be then at this point that the eating becomes more rapid, and this is when the loss of control occurs. There is obviously much more to binge eating disorder than I've just covered here. I wrote more about it in the article called Do I Have Binge Eating Disorder? And once again, I will link to that in the show notes. So the next eating disorder is bulimia nervosa, or just shortened to bulimia, and the diagnostic criteria for it is 1, recurrent episodes of binge eating. An episode of binge eating is characterized by both of the following: eating in a discrete period of time, e.g. within a 2-hour window, an amount of food that is definitely larger than what most people would eat during a similar period of time and under similar circumstances. B, a lack of control over eating during the episode, e.g. a feeling that you cannot stop eating or control what or how much you are eating. 2, recurrent inappropriate compensatory behaviors to prevent weight gain, such as self-induced vomiting, misuse of laxatives, diuretics, and other medications, fasting, or excessive exercise. 3, the binge eating and inappropriate compensatory behavior both occur on average at least once a week for 3 months. 4, self-evaluation is unduly influenced by body shape and weight. 5, binging and purging does not occur exclusively during episodes of behavior that would be common in those with anorexia nervosa. So some things I want to mention with this. Bulimia, like other eating disorders, has a stereotype associated with it, and many people believe that the purging means vomiting, and that without vomiting it can't be bulimia, but as the criteria shows, this is not the case. I also think that it is interesting to think of the criteria for bulimia and see how similar it is to anorexia, especially if someone is using exercise as their means of compensation, which with the clients I work with is so common. Because if someone is using exercise excessively and are having times of binging, what is the difference between anorexia binge purge subtype versus bulimia nervosa? And the same can even be true if someone is using vomiting as their means of purging. Like, why pick bulimia as the diagnosis over anorexia? And I suspect that someone's weight would be the determiner here. And if someone is in a low weight body, they would be diagnosed with anorexia binge purge subtype. And if their weight isn't low enough, they'll be diagnosed with bulimia nervosa. And again, this can be seen as just semantics because recovery is recovery and what does the label mean? But I also think that for many people, the diagnosis they get is in part due to weight bias and the stereotypical ideas about what certain eating disorders look like. But I'm also mentioning this just to show the overlap between eating disorders and how similar they all are. The third criteria states that binge eating and the inappropriate compensatory behaviors both occur on average at least once a week for 3 months. But again, I don't think this should be something to get hung up on about, and there can be a lot of damage still occurring, even if it's happening less frequently than this. My comments earlier about restriction with the binge eating disorder are also true with bulimia nervosa. And with the clients that I work with, it is at the heart of the bulimia and why it's occurring. And in a sense, binge eating disorder and bulimia are very similar. And simply with binge eating disorder, the compensatory component is missing. And I would say it's not actually missing, because I think there is a lot of compensation that is still occurring for those with binge eating disorder, with the restriction, with exercise. So again, I think there is probably a lot of similarities between these two, and more similarities than most would imagine. The next eating disorder category is avoidant restrictive food intake disorder, or ARFID. And in the DSM-4, so this was the version before the most recent one, it was referred to as selective eating disorder, but it was then changed in the DSM-5 to ARFID. So the diagnosis criteria: 1, an eating or feeding disturbance, e.g. apparent lack of interest in eating of food, avoidance based on the sensory characteristics of food, concern about aversive consequences of eating, as manifested by persistent failure to meet appropriate nutritional and/or energy needs associated with one or more of the following: significant weight loss or failure to achieve expected weight gain or faltering growth in children, significant nutritional deficiency, dependence on enteral feeding or oral nutritional supplements, marked interference with psychosocial functioning. 2, the disturbance is not better explained by a lack of available food or by an associated culturally sanctioned practice. 3, the eating disturbance does not occur exclusively during the course of anorexia nervosa or bulimia nervosa, and there is no evidence of a disturbance in the way in which one's body shape or weight is experienced. 4, the eating disturbance is not attributable to a concurrent medical condition or not better explained by another medical diagnosis. When the eating disturbance occurs in the context of another condition or disorder, the severity of the eating disturbance exceeds that routinely associated with the condition or the disorder and warrants additional clinical attention. So there are 3 subtypes of ARFID, and these aren't official subtypes in the way they are for anorexia, but they've been suggested based on the scientific literature. And this is actually something that Lauren Mulheim goes into detail in our conversation. So we talked about ARFID during our podcast episode, and it's episode 232 of the podcast, and I'll link to that again in the show notes. And the first subtype is known as the sensory subtype or the avoidant subtype. And this is about an individual avoiding certain foods because of the sensitivity to it. And this could be because of smell or texture or intensity of taste or appearance or color. And this is common with autism spectrum disorders or other developmental or sensory processing experiences. The second subtype is lack of interest. And these individuals have low appetite and lack the usual drive to eat. And this isn't about restriction or a temporary situation, but appears to be a permanent state and connected to various hormones and processes within the body. The final subtype is fear of adverse consequences. And this can be fear of swallowing or choking or nausea or vomiting or pain. And often this is because there was a point where this occurred, and so a fear develops of it happening again. And in this third category about fear of adverse consequences, we could also add the fear of health implications. And this would then capture orthorexia nervosa or just orthorexia, because at this stage, orthorexia is an eating disorder that doesn't actually appear separately in the DSM-5. And orthorexia is an obsession with eating only clean or healthy or pure foods to achieve ideal health. And the usual trajectory with this is that more and more foods are removed from the diet because they are considered unhealthy. And this typically leads to weight loss and nutritional deficiencies and actually pushes someone further away from genuine health. And like I commented numerous times before, there can be overlap with other eating disorders with orthorexia or ARFID more generally. So while criteria 3 mentions that this isn't focused on weight or shape, this can become an issue even if it wasn't a primary concern when it started. So with time, there are concerns about body weight and size, or fear of weight gain, or negativity about fatness, or negative body image, or preferences for less calorie dense foods. And this may have always been there, but rises much more to the surface when someone is contemplating recovery or simply deviating from their current way of eating. So the final eating disorder category that I want to mention is the one that I've already touched on, which is other specified feeding and eating disorder, which is OSFED. And this is the catch-all category for other eating disorders that don't meet up with the specifics of the criteria that I've gone through for all the other eating disorders. So some examples of this are atypical anorexia nervosa. So an individual meets the criteria in terms of the restrictive behaviors and other symptoms, but they are not at a low weight. Bulimia nervosa, where it's low frequency or limited duration. So an individual meets the criteria but engages in binging or purging behaviors at a lower frequency or for a limited time period. Binge eating disorder, where it's low frequency or limited duration, so it's just not happening as often as the criteria makes out. You can have purging disorder, where a person has recurring episodes of purging without binge eating. Night eating syndrome, so a person has recurrent episodes of eating large amounts of food at nighttime. And then there can be combinations, which is actually very common. So there is some binge eating, then there is some purging, there is a fear about the healthiness of food, then there are stretches where the eating is more normal or is more diet-like, and then stretches where it becomes much more extreme again. So on paper, this may seem less severe, but in actuality, it's still having a huge toll on the body and is taking up an inordinate amount of time and worry in someone's life. So those are all the eating disorders and their diagnostic criteria. And what I think is often more helpful than just looking at this is also looking at the symptoms that arise because of how someone is engaging with and relating with food. Because something can look like it's low frequency or more minimal, and yet it's actually having a huge impact when we look at the symptoms that are occurring because of it. And in this section, I've put all the symptoms together rather than listing them out for the separate eating disorders. And the main reason for this is that probably 80% of them, or more than that, are symptoms that occur with each of the eating disorders, irrespective of which one it is. And there are going to be symptoms that are opposite, which is then likely to occur in one and not the other. But as I said, it makes more sense to just list all of these together. So physical symptoms. So feeling cold and increased sensitivity to the cold with the need to wear more layers. And this can lead to pain and symptoms of like Raynaud's disease. You can have numbness and tingling in the hands, feet, and other extremities. Poor sleep with difficulty falling asleep, staying asleep, increased nightmares, night sweats and restlessness, increased digestive upset, so gas, bloating, constipation, abdominal pain, loose stools, undigested food in the stools, acid reflux or delayed stomach emptying, decreased pulse, heart palpitations or irregular heartbeat, low blood pressure leading to the occurrence of dizziness and feeling faint, especially when getting up or with exercise. And this, when it's bad, can lead to blackouts, hypoglycemia or low blood sugar. And this can also lead to dizziness and feeling faint, as well as nausea. And in extreme circumstances, this can actually be deadly. Decreased metabolic rate, decreased libido, often with menstrual cycles becoming irregular or stopping altogether in women, or lack of erections or erectile dysfunction in men. Vaginal atrophy leading to pain with sex and vaginal itchiness or dryness. Brittle hair, nails, skin, and where these grow and repair much more slowly. Poor dental and gum health. Increased cravings for salt. Increased desire for hot beverages, especially caffeinated drinks. Increased frequency and urgency of urination. Muscle cramps and pain. And this can counterintuitively be worse with rest or with the cessation of exercise, at least in the short term. Decreased training performance or ability to exercise, although with something like walking, this can often be overridden. And often in the beginning, even if the body is being undernourished, exercise performance can actually increase. But as time goes on, this stops. Edema and swelling, and this can happen all over the body, but commonly in the ankles and feet and legs and arm, and then in the face, under the chin and the cheeks and around the eyes. Cuts are slow to heal. Bruising occurs more often and takes longer to heal. There's an increased incidence of bone fractures or injuries, elevated carotene in the blood, which can lead to the yellowing of the skin. There can be immune system changes, and for some, this means recurrent infections, and for others, this means never getting sick. Anemia or low amounts of red blood cells, and these are the ones that carry the oxygen, and this can lead to lower energy, but it can also lead to someone feeling tired and wired. There can be shortness of breath, difficulty swallowing, lanugo, which is fine hair that develops over the body, increased pain threshold, so you become more numb to physical body signals. It can be scars on the knuckles or on the hands, a sore throat and canker sores or ulcers in the mouth, and feeling uncomfortably full after eating, which can happen both with small amounts of food or after a binge. There can be physical changes. So there can be a reduction in heart size, there can be brain atrophy, there can be bone density reduction, there can be reduction in the actual size and capacity of the bladder, there can be electrolyte imbalance. In terms of mental and emotional symptoms, there can be increased neuroses like depression and anxiety and hypochondria and hysteria, and this can lead to suicidal ideation, increased irritability and impatience, increased paranoia and defensiveness, inflexibility in thinking, feeling like you're not sick enough, increased food thoughts and preoccupation, especially around calories and fat grams and carbohydrates and healthy eating, and this can be obsessive and also anxiety provoking. There could be a lack of interest in food. There can be a hyper awareness of food and movement and noticing what others are eating, triggered by comments of what others are doing with exercising or dieting. There can be a fear of eating too much and of calorie-dense foods and supposedly unhealthy foods, a fear of texture or smell or appearance of certain foods, a fear of weight gain and feeling fat, regret and guilt because of eating. Eating becomes highly emotional, whether that means incredibly difficult and challenging, as well as eating being so prized and defended and the highlight of someone's day. There can be dreams about food, fear of vomiting, fear of stillness and stopping moving, difficulty focusing and concentrating, although in the beginning the opposite can be true, a loss of ambition, feeling more alone and shut off, which in reality can also be the case where someone is isolating themselves more of the time. Indecisiveness with food choices, but with decisions in general. There can be obsession with weight and body checking, sensitivity to noise and crowds. And many clients, when we look into it, are highly sensitive people, so HSPs, and this can make this worse. The dulling of senses and emotions and feeling numb. Increased incidence of disassociation, often as a coping mechanism to deal with exercise or the difficulties of life, body dysmorphia and seeing the body differently from how it is in reality. And then in terms of behavioral symptoms, so there can be increased length of meal times, eating more slowly, eating foods in a specific order or other rules around eating, i.e. using the specific cutlery or plates or eating at an exact time, times of increased speed of eating and episodes of binge eating, especially when eating food one would normally avoid, chewing and spitting out of food, or regular use of chewing gum or low-calorie sweets, vomiting, taking laxative or diuretics, enemas and or fasting, hiding food and eating secretly, avoiding eating in front of others, using dietary supplements and herbal products for weight loss, cooking food for others but without eating yourself, a focus on trying to take care of everyone else instead of yourself, increased interest in preparing food, reading recipes, buying cookbooks and watching food-based TV programs, eating a limited number of foods with fear of deviating from this list, a rigid and excessive exercise routine that causes distress when you try and change it, increased walking, housework, standing, fidgeting and pacing, favoring occupations that allow for movement, withdrawal from friends and activities that used to be of interest, reluctance to participate in activities where the body will be viewed by others, i.e. swimming, and this is true even if someone's body meets up to society's standards and they supposedly have nothing to hide, engaging in self-harm, frequently dieting, possessiveness and hoarding, so cookbooks or recipes, or keeping the fridge completely stocked with food, also hoarding non-food items, so plastic bags or magazines or cleaning items, etc. Kleptomania, which is the urge to steal, and this can be food items, that can be non-food stuff as well, eating food out of bins or food that has been thrown away, compulsive spending or being extremely frugal, and these are opposite ends of the spectrum, but both can occur, prone to forming strong habitual habits, increased OCD or OCD-like behavior, and increased ability to lie, particularly in connection with food. And this isn't always the case, but if someone isn't ready to give up the disorder, this can be occurring. So that is a very long list of symptoms that can be common with eating disorders. And I guess when you hear that list, how much does that match up with your own experience? How many of those symptoms are things that you are currently experiencing right now? So I now want to look at the different aspects of the recovery process. And these are all things that I work on with clients. And for some, it will be more of one or more of some than others. But this is looking at recovery broadly and all the aspects that are interconnected. So the first area is nutritional rehabilitation. And so many of the symptoms that are connected to eating disorders are due to malnutrition. And as part of the things that Sasha Gorel listed as commonalities with eating disorders, weight suppression is one of them, and weight suppression for where the body historically was. And when the body is getting less energy compared to what it needs, it has to make cuts. And no organ or body system is spared from this. And as a result, symptoms start to occur, like the long list that I just read out. And I've done articles looking at relative energy deficiency in sport, or RED-S, on hypothalamic amenorrhea, or HA, and fairly recently did one on bone health. And these all look at the processes by which reduced energy impacts the body. I've also done a very detailed podcast on the Minnesota starvation experiment that really demonstrates how energy depletion affects every part of the body, and that so many of the symptoms that the men experienced as part of this experiment then match up to eating disorders. So I'll link to those articles and the podcast in the show notes. One area that is affected by malnutrition is the brain, and this leads to changes in thoughts and belief, and personality can also change. And sadly, while this is occurring, it can be hard to grasp how much this change has occurred, and you can lack the awareness to truly appreciate how things have changed. And it can feel like this is just me, or this is what I truly believe or want. But once out the other side, it is amazing how these beliefs and thoughts change, and where someone can finally see how much this was then being driven by the insufficient energy. And these brain changes are something that I touch on in the Minnesota starvation experiment, because it was one of the things that they looked at as part of that. But I've also done a whole separate episode on how the brain is affected by restriction and being in a low energy state. And so I'll add that to the show notes as well. And I need to stress that nutritional rehabilitation is important in all eating disorders, irrespective of the body that someone is in. It can be easy to believe that this is only relevant if you are visibly emaciated. And interestingly, as a demonstration of just how much the brain is affected by energy depletion, even for clients whom I work with who do match up to that stereotype of being emaciated, and even when they can acknowledge that their body looks too thin, they still struggle with the idea that they could really need more food. And in my previous conversation with Fiona Wheeler, we talked about malnutrition in higher weight bodies and how this is definitely a thing and can be hugely damaging to the functioning of the body. So someone can still be experiencing the same symptoms as someone in a much lower weight body, even if their body doesn't match up to the stereotype of what malnutrition or a malnourished body looks like. And again, I'll link to the Fiona Wheeler episode in the show notes. I also want to add that this is relevant even if binges are occurring. Like, there can be this false belief that if binges are occurring, then the body must be getting what it needs, or believing that it's even getting more than what it needs, and nutritional rehabilitation is therefore irrelevant. But as I mentioned earlier, restriction is a part of the picture for all eating disorders, and this is true even if binges are occurring. So the goal of nutritional rehabilitation is to get the body out of the depleted state it is in and provide it with the resources it needs to repair. And this means not just meeting your energy demands for today, but also paying off all the energy debt that has accrued. Because obviously there is damage that occurs from being in a malnourished state for an extended amount of time. And what this nutritional rehabilitation looks like will depend on someone's current situation. And part of this, as I said, relates to how long it's been going on for and how depleted the body is. But it also relates to the ability that someone has to take in more energy and to move out of this place. And there can be psychological reasons why someone is increasing their intake at a slower pace, that it just feels too overwhelming to make changes too quickly. But there can also be physical reasons why this is occurring too. And I've done articles before on how digestion, for example, can be affected by recovery, because if it is slowed down and there's slow gastric emptying, it can be a real challenge to take in more food quickly. And so it may need to be going at a slower pace. So I'm not going to give a specific plan here for what nutritional rehabilitation looks like, because there isn't one plan that someone has to follow. But I do want to just stress how important it is. And once again, this is something I cover as part of the Minnesota starvation experiment, where I go through the recovery that the men experience and what this looked like for them. And while you may not want to hear this is not going to be a quick fix. This repair takes time. And as much as people want to avoid it, it is completely necessary. If the body is given the resources and this happens for long enough time, it truly can heal. So the next area is brain repair and neural rewiring. And as I just mentioned, malnutrition affects all parts of the body, and the brain is no exception. And brain matter actually shrinks, and these physical changes then lead to changes in personality and beliefs and thoughts and behaviors. And to reverse these changes, increased energy intake needs to occur. And this extra energy then facilitates that recovery. And so a big part of the nutritional rehabilitation that I just covered is helping here. But in addition to the energy intake, there also needs to be a learning of new habits or patterns of behavior at the brain level. And this is known as neural rewiring. And there's an oft-used phrase that cells that fire together wire together. And what this means is that the more that you do something, the more it becomes ingrained. And this is definitely the case with eating disorders. Like, the more you've acted on behaviors connected to eating patterns and rituals or exercise and movement regimes, the more these become normalized and habituated. And this is a topic I touched on a lot in my conversation with Sasha Gorel, whom I referenced at the start of the podcast. And if we think of eating disorders being an anxiety disorder, then the approach for dealing with this is exposure. And it is doing things that are in support of recovery, even though they are challenging. And they're challenging because the brain has been wired based on repetition, and we're now doing something different. And based on the conversation with Sasha, I wrote a blog post all about anxiety and behavior changes, this process of neural rewiring. So I'll link to that in the show notes. It's also a topic that is covered in Tabitha Farah's excellent book, Rehabilitate, Rewire, Recover. And this book is fairly directed towards anorexia recovery, but many of the suggestions are fairly universal for all eating disorder recovery. I've also made reference to my conversation with Lauren Mulheim, and where we talked about RFED and the 3 different types of RFED. And we actually go through each of the different recovery processes and how they look different and how these approach. And a part of this is then connected to the neural rewiring and how the connection to food and food behaviors is then changed. And I think it's important to understand this neural rewiring process, because when in the midst of an eating disorder, it can feel like things are permanent. That these are my go-to ways of behaving, and these are my go-to ways of thinking, and they're just so automatic, and I don't ever see them changing. And I want people to know that change can and does occur. But like I mentioned with nutritional rehabilitation, it is slow. And these changes to the brain can take a lot longer than you would like. And this is true of the physical repair to the brain as well as the neural rewiring. So in the beginning, it is doing things that feel uncomfortable, where it feels like there is little or no improvement. But with enough time, this does then change. And one of the biggest areas that needs neural rewiring is connected to food. So this is the next area, and it's like challenging food rules and food fears. And as I talked about in the very beginning, one commonality that all eating disorders have are a fear or fears about the consequences of eating. And this fear or fears changes how food is seen. It is seen as a threat. And much like when we see a snake or a spider, it sets off the body's stress response. And eating can become a terrifying experience where you want to find the foods that you label as safe to minimize this discomfort. And as a way of trying to mitigate this fear, certain rules and rituals arise. And this could be connected to the types of food, the order of eating, the timing of meals, the setting, the types of plates or bowls or utensils. And these are behaviors that are then a way to try and soothe the uncomfortableness of mealtimes. And recovery is therefore about rewiring the body's response to food and teaching it that what it currently fears and leads to a stress response is actually safe and does not warrant this kind of response. And this is done by challenging those food fears and those food rules. Depending on the type of eating disorder and the types of rules and rituals that have developed will affect how this looks. So for example, if there are rules about certain foods that are off limits, it would be bringing these foods back in. If there are rules about not eating before a certain time or after a certain time, it would be doing the opposite to this rule. If there are rules about certain plates or cutlery, it would be changing and using different utensils. And sometimes it's not about rules, but about certain fears. So for example, if I reach a certain level of fullness, this is what always leads to a binge or leads to a purge. Or if I fear to keep certain foods in the house or buying certain foods as a multi-pack because I worry about having them around in the house. And again, in Tabitha Farrar's Rehabilitate, Rewire, and Recover, she lists many of the different rules. And I said earlier, like this book is more specific for anorexia recovery, but many are fairly universal and apply to most or all eating disorders. And so whatever the rule is or the fear is, it's about working to overcome this. And how this approach will vary. Like sometimes it is doing the proverbial ripping the Band-Aid off, and by directly challenging the fear and doing so repeatedly, it then dissipates and is no longer a challenge. Other times it's about small changes and working the way up. So looking at the problem and breaking it down into smaller chunks. In other circumstances, it may take working on the issue in a more indirect way. So for example, binges may be associated with eating a certain food, but actually when we dig in deeper, this is occurring because of the restriction that is happening beforehand and the times that someone eats that particular food, they are very, very hungry. So whenever the supposedly triggering food is eating, there is this build up and this chain of events that goes back many hours or even days. So then to deal with this fear, we focus on the aspects leading up to this point. And then when someone has that previously triggering food, because they are in a different state, it has a different effect and it doesn't lead to a binge. And so all of this is just to say that challenging food and food rules and food fears can be done in a variety of ways depending on what is most appropriate for the situation. And by doing this, it can help with both nutritional rehabilitation and the neural rewiring process. The next area to look at is exercise and movement. And once again, this can be having an impact on both nutritional rehabilitation and neural rewiring. And for many clients, exercise compulsion and overexercise are a part of their eating disorder. And often this can be about managing weight or as a way of compensating for eating, or because of the supposed health benefits, or as a way of managing anxiety. And this can take many different forms. It can be HIIT classes, boot camps, spinning, yoga, running, walking, cycling, triathlons, rock climbing, marathons, weight training, bodybuilding or physique competitions. I would also add that other forms of movement are also worth noticing. So, for example, many clients are spending huge amounts of time cleaning each day. And even though this may not feel like exercise, it's clearly using up a lot of energy and is also a compulsive behavior that they feel compelled to do. And despite how exercise is talked about, it isn't always this positive thing for health. To benefit from exercise, the body needs adequate calories, adequate rest and repair. And with the clients I'm seeing, these other components are missing. So exercise turns from something that can be healthy into something that is just further depleting the body. And our relationship with exercise is equally important, because there's a difference between genuine enjoyment compared to compulsion or needing to exercise to change the body or to make up for the food that was eaten. So for recovery, this means a change in exercise and movement habits, and also a change in the relationship to exercise and movement. And now, like I talked about with challenging food rules, this can look different depending on the situation. It may mean a reduction in the total amount that is being done. It may mean changing from one form to another, or maybe something that is gentler. It also might mean a total cessation, at least for some length of time. And I know for so many clients, it can be hard to go back to a form of exercise that they did as part of their disorder. And there's just too much association with that form of exercise. Now, this doesn't mean that there isn't some pull to go back to that exercise. Often there is. But when they start to do it, they notice that it just doesn't work for them. And interestingly, what I've noticed with clients is that this pull does disappear with time. For example, there is this desire to get back into running. They are making changes and having a break, but there's still this belief that this is temporary and they're just counting down the time until they can get back into it. But at some point, this urge just disappears. There's a realization of how destructive it was, or how they didn't actually enjoy it as much as they tell themselves or were telling themselves. And when they then do get back into movement or exercise, it is doing new things that aren't associated with their eating disorder, or rediscovering ways of moving that they did as a kid or before the disorder happened that had then dropped away. And obviously this isn't the case with everyone, and for some they do find a way to go back into the exercise that was associated with their disorder, but to do this they learn to have a different relationship with this exercise. And as part of the neurorewriting piece and breaking free of the compulsive nature, I really focus with clients on building psychological flexibility. So maybe they start out slowly, where it's once a week, and then it becomes twice a week, and then it's 3 times a week. And this then takes a long time to build up. So there's a real intention of not rushing this. But when they are doing it, say, 3 days a week, rather than doing this all the time, can they still mix it up? So can they then have diet times of doing it twice a week or once a week, or having weeks off, and really constantly proving to themselves that they are in the driving seat? And over the long term, this might not be necessary to keep up with this kind of intentionality, and maybe it just starts to happen naturally because of the busyness of life and how someone is feeling. But in the early years of recovery or after recovery, I think it's important to really understand just how fragile and precarious this time is, and really needing to constantly build that resilience and that psychological flexibility. So the next area to look at, or more accurately, like skill to learn, is that of urge surfing. And the term urge surfing was developed by the psychologist Dr. Alan Mallet, and was particularly or originally used for drug and alcohol addiction. And an urge is an impulse to engage in a particular habit. And with eating disorders, this could be an urge to restrict or to purge or to exercise or to binge. And the reason this is referred to as urge surfing is that urges are like waves, in that they rise in intensity, they then peak, and eventually crash all of their own accord. So, for example, after eating a meal, there could be an urge to do some compensatory behavior. And this urge rises up and can feel like it is all-consuming unless you give into this urge. But if you avoid acting on this urge with enough time, the wave of desire to do this will come down on its own. Now, it may take an hour, it may take many hours to come down, so it's not instantaneous. And it's not that the urge comes down to zero. There may be still some baseline pull towards that behavior, but the intensity is reduced and come back to what we could think of as baseline for the current state that the body is in. This is a practice. Like, just becoming aware of this concept isn't enough. And a big part of urge surfing and making it work is having an open and curious and non-judgmental mindset, because the time it takes for the urge to pass is connected to the response that someone has when that rises up. So, for example, it's said that the lifespan of an emotion is 90 seconds. And that is how long it takes to flush out the chemicals in the body that created that emotion. But I know for myself, like, emotions typically last much longer than this. And that's because we usually do things to keep these emotions alive. And this is true for both positive or negative emotions. We use our thoughts and our actions to keep that emotion alive. And sometimes this is a wonderful thing. Like, we get to experience longer periods of joy or excitement or contentment or other present emotions. But it also means that emotions that we label as negative emotions, so anger and rage and overwhelm and embarrassment or shame or really any of the negative emotions, also last for a longer period too. And I would say that I believe it is highly unrealistic to think that as humans, that anytime a negative emotion arises up, we believe that within 90 seconds we will be past it. Like, I think that is an absolute pipe dream. But I do think it is worth recognizing our role in perpetuating these states. And so how does urge surfing work? How do you do it? I can give a very simple example. So when an urge rises up, you stop and you notice the sensations in the body. So where are these sensations located in the body? What do these sensations feel like? Does it feel like pressure, tingling, warmth or coolness? How much space do these take up in this place in your body? Could you draw a line or an outline around the place where the sensations are felt? Are there any movement to these sensations? Some people tend to associate sensations with color or with temperature. So can you check to notice, are there any color or temperatures associated with these sensations? You can then bring your attention to the breath and keep going with building this level of awareness about this experience. And so that's just a very short example. That's not how urge surfing has to be done. There are many different ways, but you're doing all of this from a place of non-judgment and simply being a witness to the experience and curious about this experience. And while I'm talking here specifically about urge surfing, I think this is simply one part of really the bigger picture of mindfulness and becoming aware of our inner experience, whether that be thoughts or feelings or sensations. And it's learning the ability to then be present, to be aware with what we're doing in our immediate surroundings. And there are lots of different ways of doing this. Like, I'm a big advocate of acceptance and commitment therapy, or ACT, and I don't necessarily know if this is the best way, but it is simply the one that I know best. I highly recommend Russ Harris's book, The Happiness Trap, as it is a great resource on this topic. Emotion coaching is also part of this and is something that I talked about with Adele LaFrance, at least in the earlier part of the conversation that we had together. And she is the co-developer of emotion-focused treatment modalities, and one of these being emotion-focused family therapy. And a big part of this approach is emotion coaching. And her work is based on, or is drawn from, the work of the Gottman Institute, which was founded by Doctors John and Julie Gottman. And their work is very much aimed at parents and helping parents to help with emotion coaching with their children. And with Adele's work, it is similar, where she's also helping parents to emotion coach their children. But even as an adult, I can read the material, like I can read John Gottman's book, or I think it's John and Julie Gottman's book about emotional coaching for children, and it can be completely relevant for me. And in a sense, I play the role of both parent and child. And so where my emotions arise, I'm helping to guide myself kindly and compassionately to become aware of my sensations and my emotions, where I can validate my own feelings and see if I can label the emotion accurately and then figure out how to deal with this situation constructively. Using an emotion wheel with this can be a helpful starting place to remind you of all the different kinds of emotions. Brene Brown's book, Atlas of the Heart, is also really helpful here. It goes through 30 or 40 different emotions and explains them in detail. An understanding of polyvagal theory, I think, can also really be helpful with this mindfulness piece. And I cover this in my podcast with Deb Dana, and she's one of the people who has written most extensively on this topic and actually written in a way that is very useful for both practitioners and for the lay public. And again, I'll link to all of these things I just referenced in the show notes. And very much connected to this idea of mindfulness is compassion, and particularly self-compassion. And recovery is challenging and it is messy, and the body responds in ways that you would like it not to. And I think one of the best and biggest antidotes for this is self-compassion. So Dr. Chris Sandel is a pioneer in the field of self-compassion research and has probably studied it more than anyone else. And she defines self-compassion as having three main characteristics. So one is self-kindness instead of self-judgment. So recognizing that we are imperfect, we'll make mistakes and go through difficult experiences. And in these moments, we need to treat ourselves with kindness. Two, common humanity instead of isolation, recognizing that suffering is part of being human and is a shared experience, not something that is only happening to you. And three, mindfulness instead of over-identification. So recognizing how our thoughts and feelings actually are, so they are not suppressed nor exaggerated. And like urge surfing, self-compassion is a skill. It's something that you can learn to do. And with most clients, I actually start by looking at the fears of compassion scale that was developed by Paul Gilbert. And it looks at fears connected to giving compassion to others, receiving compassion from others, and receiving compassion from ourselves. And this was a scale that I learned from Josie Geller, whom I had on the podcast, and I'll link to in the show notes. And she's done a huge amount of research looking at recovery and compassion and how they are, or compassion is, correlated with recovery, but is also a predictor in the likely success of recovery. But I want to add again that our level of self-compassion isn't fixed, and it is a skill that can be learned and can be increased. And in the area of compassion, I want to mention two other people who I think are fantastic. One is Tara Brach. She's written many books on the topic. She's also done many meditations on it. And her style is a little different to Chris Sandel, and I tend to find that clients prefer one over the other, but which one varies. So if you start with one of them and it doesn't resonate, try the other, or just try them both and see what you notice. The other person is then Beverly Engel, who has also been a guest on the podcast. And she has a background in different forms of abuse. And for those who have suffered abuse, they can have a particularly difficult time with compassion. And so this can be helpful if this is your background, because Beverly's work really speaks to and deals with aspects that are specifically connected to this. The final piece that is connected here is acceptance. And I do think that there is an overlap between all these ideas of urge surfing and mindfulness and compassion and acceptance. And I wrote a blog post recently all about acceptance and why, like self-compassion, it really is a key to recovery. So I will link to all of those things in the show notes. The final part I want to mention connected to this section on mindfulness and emotions and self-compassion is the importance of developing healthy coping skills. And while eating disorders can have many reasons for forming and can serve many functions, one function is as a coping mechanism. And people keep up behaviors that are serving them in some way, like irrespective of how much pain or damage a behavior may cause. If it's being kept up, there is some positive intent or positive outcome because of it. And because of this, I'm a big believer that people keep their problems for a reason. And in this sense, these aren't actually problems, but they are solutions. And this doesn't mean that it is the best solution, but at least at this time, it's the best solution that someone has come up with. So the goal with the recovery is to understand, like, what is the eating disorder doing for you? What benefit is it providing? What need is it meeting? And some examples for this are, it allows me to deal with anxiety and makes me numb. It calms the loop of critical thoughts in my mind. It helps me forget about the trauma I've experienced and makes my life small and manageable. It helps me feel worthy and that I have value. I'm a perfectionist and it helps me feel I'm doing things right. It makes life easier because I don't have to face the things I'm afraid of. And so really by answering the question of, like, what is this doing for me, we can start to understand, like, how is this helping? And then start to figure out alternate ways to cope other than the eating disorder. And I've already touched on many of these already in terms of urge surfing or acceptance and commitment therapy or polyvagal theory and self-compassion, but it can also include lots of other things and ideas that can be directly connected to the eating disorder and what to do in specific situations that are connected to that, but also a lot of work on bigger picture aspects of life, where for someone they are like creating a life that becomes in opposition to the eating disorder. And so life is then pulling you towards recovery. And this final point then connects to the next area of recovery I work on with clients, which is looking at identity and values. And in psychology terms, our identity is a collection of beliefs and feelings about how we see ourselves in the world and that make us who we are. And our identity includes how we believe others see us and our social identity, so our perceived membership to or exclusion from different social groups. And it encompasses our memories and our experiences and the relationships we have. And for those with an eating disorder, identity can be connected to how they eat and how they exercise and the shape or size of their body. And that you may think of yourself or are known by your friends as the fit one or the healthy one or the lean one or the thin one. And these attributes then can become integral to who you are in this world, and keeping up these habits can then become immensely important. And to get a sense of identity, you can ask questions like, I'm the kind of person who fill in the blank. Growing up, I was always the one who fill in the blank. People who love me would say I am fill in the blank. People who don't like me would say I am fill in the blank. My work colleagues would say I'm fill in the blank. And then values are things that you believe are important. And to quote the happiness trap on this, values are our heart's deepest desires, how we want to be, what we want to stand for, and how we want to relate to the world around us. They are leading principles that guide us and motivate us as we move through life, end quote. And values also touch on things like ethics and morality and a person's sense of right or wrong or what ought to be. So to help discover your values, you can answer questions like, what do I want to be? Who do I want to be? What is important? What really matters in life? Imagine you are in the future 10 years from now and you're looking back on your life as it is today. Complete these 3 sentences. I spent too much time worrying about blank. I did not spend enough time doing things such as blank. If I could go back in time, the things I would do differently are blank. And you can also go through a list of values and pick out the ones that resonate with you. And so with clients, I use a list compiled by James Clear, which I'll link to in the show notes, and ask clients to pick their top 5 values. And we can then use this work around identity and values to explore someone's current life situation. What are the parts of their identity that they like and want to keep? What are the parts that they would like to change? How has the eating disorder impacted on their identity? Based on what they wrote for values, how much is this matching up with their current life? Is what they wrote a reflection of their lived experience, or are the values at this point much more aspirational values? How is the eating disorder currently in alignment with these values? How is it not? And for nearly all clients, they're able to see that the eating disorder is not supporting their true values. And so it's then about figuring out ways that they can change so that this can be different and they can be living more in alignment with their values. And as a knock-on effect, their sense of identity will start to shift. Now, like many areas I've already talked about, this isn't a quick process. But I really like this values work, as it can be like a North Star and help with choices and decision making, even when these things are challenging. And part of this is because it can help someone to see their true self as separate from the eating disorder itself. And that while the eating disorder may be loud and at times feel like who they are, they can notice that actually it has values and desires that are different to their true nature. So the next area that is important to work on is body image. And one of the main features of anorexia and part of the diagnostic criteria in the DSM-5 is an intense fear of gaining weight. But as I went through, when we look at all the different types of eating disorders, is that there is a fear of weight gain or body or shape changes or a real focus on self-evaluation based on how the body looks. And so really this area of body image, I think, is a hallmark of nearly all eating disorders. And this fear is there irrespective of someone's actual weight. Like no matter how low weight goes, this fear never abates. And in fact, it often gets stronger. And a part of this fear is connected to malnutrition and how the eating disorder affects someone's thoughts and perceptions. It is incredible how many clients I've worked with or am currently working with who talk about how they never had fears or concerns about their weight or their body shape or size before developing the eating disorder. And it's not that these people constantly felt incredible in how their body looked. There could be times of feeling insecure before certain events or at points during puberty. It's just that on the whole, their body and how it looked wasn't something they thought about much, and it wasn't really part of their identity. But once the disease then took hold, then the panic about the weight gain ensued. And Tabitha Farrar is an example of this, which is something we discussed when she was on the podcast. But I would also say for many people, or maybe most people, body image and weight concerns were a problem before the eating disorder started. And then the eating disorder came along to supposedly help this and actually significantly intensified it. And body image in simple terms is how we feel about our body. And if we broaden this out, we can look at the various components that then impact on how we feel. So there is visual, like how we see our physical body, and this is never actually as the body is, but is our perception. There is then the emotional, so the meaning and the beliefs we assign to our body. There's the kinesthetic, so our perception and connection to the movement and the sensations of our body. Historical, so the lifetime of experiences our body has endured. There's behavioral, so the actions and behaviors that we take based on our body image that then further reinforces our thoughts and feelings and beliefs. And I recently had Summer Innanen on the podcast, and the whole episode was all about body image. And one of the most important parts of that conversation is how body image is so connected to self-worth. And much of the work on body image isn't necessarily about how we feel about our appearance, but other aspects of who we are and our sense of worth and our value in the world. And dealing with this comes back to so many of the areas that I've already talked about in terms of mindfulness and urge surfing and acceptance and polyvagal theory and healthy coping skills and identity and values and self-compassion. And it can also be looking at things directly connected to appearance in terms of beliefs about thinness and fatness, or doing mirror exercises or doing photo exercises. But it's important to understand that what is often talked about as body image work is really the top of the iceberg. And actually, we need to look at all the aspects below this. After the summer podcast, I also wrote an article all about body image, which I'd also suggest checking out. So I'll link to both the article and the podcast in the show notes. So the next area that is useful to look at and explore is to understand why the eating disorder developed in the first place. And for me, this is then in service of helping recovery and is has a very practical application, because it can be very easy for this kind of exploration to turn into something that feels very interesting, but doesn't lead to actual recovery. And in my conversation with Emily Trushanko, we talked about this and how it can be a trap where it feels like we're unearthing stuff about childhood or about someone's personality traits, but actually recovery isn't taking place. And I'm in agreement with her on this. Like, this can't be all that recovery is about, that recovery occurs via action taking. But where I see this kind of extrapolation as being helpful is how is it affecting the current situation, and is there specific forms of treatment or changes in the way that recovery is approached because of this, or are there things that the client can now do differently based on this new information? So let me go through a number of ideas to just give you a bit of example of how this could be helpful. So highly sensitive person. This is something I did a podcast on with Barbara Allen and looked at what this is. And if someone is a HSP, this is a permanent trait, and this is going to affect their nervous system and how they will experience and tolerate certain situations. So if this is someone's nature, knowing that this is their nature is really important, and they can then, as part of recovery, be focusing on creating a life that honors this as part of their nature, and it helps the HSP aspect to be a strength rather than a weakness. And so often when I'm working with clients, they are unaware of this. And so being able to learn this is very helpful in them just understanding more about who they are and why things are occurring. Autism spectrum disorders is another one. And this is something I'm seeing much more with clients. And like with being a HSP, this is permanent. It's not something that is going to change. And it is so common that clients have developed an eating disorder to deal with the feelings of overwhelm that comes with the autism. Or more accurately, they don't even know that they have autism, and they're then living in a world that isn't set up for it, that isn't respecting that as their experience. And so receiving this, and again, I'm not a psychiatrist, I don't diagnose with anyone with this, so it's like exploring this and then saying, okay, cool, like let's figure out what the path forward with this is to get an official diagnosis if that's what you want to do, or to understand how this is having an impact. And so it can then be looking at what further things need to be done because of this, in terms of helping everyday life, in terms of helping the recovery process. ADD or ADHD, and this is similar as I'm talking about with the autism or the HSP piece, and is something that affects how someone processes the world and their internal experience. And I had Roberto Olivadia on the podcast recently to talk about this, and so I'll link to that one in the show notes as well. Trauma. Obviously, trauma can mean a huge range of different experiences, and it can have a massive impact. And for many clients, their eating disorder developed as a way of coping with the trauma they experience. And I recently did a podcast looking at the many different types of trauma healing modalities and how they can be useful. And so it can be worth seeing if this kind of thing is needed in addition to the eating disorder recovery. Anxiety disorders. While eating disorders in the long term make anxiety worse, for many clients, their anxiety predates the eating disorder. And as I talked about with Tasha Gorel, recovery doesn't necessarily take away this anxiety. So in a sense, anxiety is a trait, not just a state, and it's looking at how to deal with that. Parents' beliefs about food and body. And this can be part of the reason an eating disorder starts, but it also can make recovery more challenging because of the fear of being judged or being ostracized. And I would expand this out and say parents, or a parent who is a narcissist or who is a bully or has a negative impact on the child. And maybe this then falls under the bracket of trauma, which I've already just mentioned, but seeing as I'm talking about parents here, I thought I would add it. And I spoke with Harriet Brown on the podcast all about her experience with a narcissistic mother and her book called Shadow Daughter. And I think this is an important thing to recognize. Food insecurity. And this may be something that is still going on, but it may be something that is in the past that is still having an impact. And in my conversation with Michelle Vina-Baltus, she talked about how the pandemic triggered old memories and fears of food insecurity. And this is despite the fact that it had happened decades ago and that she's done a huge amount of work and now has a very healthy relationship with food. But this experience in the past can be having an impact. Living in a body that is deemed unacceptable by society. And this could be because of race or ethnicity, it could be transgender, it could be because of disability, it could be because of size. And recovery in a lot of ways isn't going to change these things. And recovery could be taking away the thing that helps someone to feel special or feel like they are passing or feeling like they are acceptable. Loneliness or isolation or boredom. And this is something that is very common with clients in their 40s or 50s, with kids leaving home or with entering retirement. And for many, this can be the point of life when the eating disorder develops, at this midpoint of life. Body dysmorphic disorder, or BDD. So we often think that body dysmorphia as being a symptom of an eating disorder, which it absolutely can be. But kind of like I mentioned with anxiety, for many clients, this can predate the eating disorder. And the eating disorder has been a way of trying to manage the BDD, but even when they recover, this is still going to be around. Digestive issues or other health problems. And again, it's often that these predate the eating disorder and are very likely still going to be around after the recovery process. And so the eating disorder had been an attempt to try and deal with this and is going to be a problem or something that someone's going to have to deal with after the recovery. And there are lots of other ideas: low self-esteem, going through middle school or high school or college or moving overseas, parents divorcing, a parent going to prison, getting married and the lead up to the wedding, getting into marathons or triathlons or yoga and this becoming a strong part of someone's identity and social group, going through puberty and this feeling too early or too late. And there are obviously lots of other ideas, but hopefully this gives you a sense of some of them, and where we can explore how these traits or how these experiences has shaped someone's life or their beliefs or their sense of self, and how this is then connected to current actions and current behaviors they're making. And again, from the very practical stance of understanding this so that it can then aid in recovery. So they can then get support to better understand their autism, or they can learn to set boundaries with their narcissistic mother, or they can find a provider that offers EMDR to help with their trauma. Like, I think understanding the driver here so that you can know why it is still having or how it is still having an impact can be really important. So those are all the areas I want to mention as part of recovery. And undoubtedly, I've forgotten things, which is what regularly happens after I post these episodes. I suddenly remember all the other things I should have added in. And everyone's recovery journey is different. And some of the above are going to be more prominent and salient for some than others. And one thing I do firmly believe in is full recovery is possible. And as I discussed with my recent conversation with Colleen Reichman, not everyone's goal is full recovery. Someone may be after harm reduction, and it's not for me to tell this person that they are wrong and that full recovery is the only goal they should aim for. But what I want to do is be an advocate for full recovery, in that helping people know that it does exist and that it is possible. And I want to have the belief and the hope when the eating disorder impacts on someone's ability to envisage this for themselves. And it's so common for me to see clients who are trapped in a place of quasi-recovery. And in fact, this is often why people reach out to me, because I've written so many articles on this and they've read so many articles they've written on this, and it then really resonates with them. And so I will link to these articles in the show notes. And so quasi-recovery means partial recovery. And in fact, everyone who reaches full recovery will go through this stage. And quasi-recovery is when things aren't as bad as they were when they're at their worst. So you're now feeling less cold. You're now able to eat foods that you couldn't eat before. You're now not following a rigid exercise routine, and this then frees up more time for you to do things that help you feel more satisfied. You have an increased ability to concentrate and find that you're less irritable. And what turns quasi-recovery into a problem is when the process of recovery ceases to move forward. So rather than quasi-recovery being like the place that you travel through as you go to a place of full recovery, it now becomes the destination and the place that someone stops at. And there can be many reasons for this occurring. It can be a misunderstanding about how much recovery has occurred and yet how much more there is to go. So, for example, this extreme hunger has stopped, or the binges or purging has stopped, or periods have come back again, or exercise has been ceased for some amount of time, or blood markers have improved. And there is some marker or markers that are being used to determine that recovery is over, when in fact there is still more to occur. Or the very common one, that some weight has been reached, that a goal weight that was set has now been achieved. Or someone simply believes that they are at a weight that is enough, and that this indicates that recovery must be over. And I actually wrote a whole article on this and how it not only impacts an individual's belief, but also how it impacts research outcomes and how recovery is defined. And why this is such a problem is that while things have improved, they haven't improved entirely. And yet someone can get the impression that this is as good as it gets. And if they are noticing that life isn't really that much better, then it's easy to go back towards disordered behavior. And why I want to take such a broad view with recovery and look at all the ways that it has infiltrated into someone's life is because someone may have reached a place of nutritional rehabilitation, but if there's still a lack of coping skills or an inability to set boundaries, or there's a lack of self-worth or self-compassion, then these are areas that need to be worked on, because if they aren't, there is a high likelihood that relapse will happen. And the greatest risk of relapse is up to 18 months after recovery, but it can still happen much later than this. And I've had many clients who have recovered from an eating disorder in their teens or early 20s, only to then relapse in their 30s or 40s. And a big part of this is because there were skills that weren't learnt in the recovery process first time around. So for me, full recovery isn't simply about being able to accept your body size and shape and no longer having a destructive or damaging relationship with food and exercise. It's about building the skills and the resilience in all areas of life, which is so much of what I've covered today. Because I've never had an eating disorder, but so much of what I've covered, whether it's about mindfulness or self-compassion or noticing sensations and emotions or values, etc., is critical to my well-being and healthy functioning. And this is going to be an ongoing and a lifelong practice. And so I do use the term full recovery rather than in recovery, like is common with AA or recovery from other drugs. But I still think of this being a lifelong practice, or at least much longer than the idea of just putting in work for 6 months or a year and then being recovered. This is a long-term project with the time at the start obviously being much more acute, but where you can learn things in year 3 or year 4 that are every bit as valuable. So recovery is challenging and it isn't a quick fix. And I really do believe that getting support is an important step as part of this process. Because while there are those who have truly recovered on their own, I think of them as the exception and not the rule. And it can feel scary or embarrassing to seek help for an eating disorder, which is why I think it is crucial to get help that is supportive and is non-judgmental, because you don't have to pretend that you are fine when you really aren't. You also don't have to pretend or hide what's going on for fear that you're going to be lectured. And despite the eating disorder thoughts, there is a healthy part of you, and one that sees all the problems that this is causing and how much life has fallen by the wayside, and that you would like life to look differently. And ambivalence is at the heart of all change, and this is especially the case with recovery. And it's totally normal to fear recovery and to long for it at the same time. And I've worked with clients for over a decade now, helping them to recover from many different types of eating disorders. So if you want to recover, even if you feel ambivalent, like I would love to have a chat with you. As I mentioned at the top, I'm currently taking on new clients. If you want to head over to 7-health.com/help, you can read more about how I work with clients. I offer a free initial chat where you can talk about what's going on and where you'd like to get to, and you can find out more about what working together would look like. I want you to get to a better place with recovery, whether that is full recovery or harm reduction, and I would love to be able to support you through that process. So that is it for this week's episode. I hope that you found it helpful. If you have, and there are others who you know of or you have in your life who you think would benefit from it, like please share it. It has taken a lot of time and effort to put this together, and I want as many people to hear it and benefit from it as possible. I'm away next week. I'm on holiday in the New Forest. There will be a rebroadcast episode coming out then, but I will be back with a new episode shortly. Until then, take care, and I'll catch you soon.